Hi, my name is Rachel Ibarra, and today I'm going to be discussing my topic for the evidence-based research presentation, electrical stimulation for patients with spasticity deficits. The study that I have reviewed is called The Effects of Functional Electrical Stimulation on Wrist Function and Spasticity in Stroke, a randomized controlled study. The hypothesis or the purpose of the study is, does functional electrical stimulation affect wrist function and spasticity recovery in individuals post-stroke, chronic, or subacute? The type of study or the level of evidence is a level 1 randomized control trial. The sample size for this study were 28 individuals. There were 14 people in each group. The inclusion criteria for this research study were you had to be 18 years or older, have existence of the first and unilateral stroke attack. Time of the stroke is over 1 month, but less than 6 months. And patients without any contraindications of functional electrical stimulation, as well as communicative and cognitive skills. The exclusion criteria for this research study were patients with a pacemaker, joint range of motion limitation within the shoulder and the wrist, severe cardiac arrhythmias, CRPS or complex regional pain syndrome, and patients with lower motor neuron lesions. Patients were divided into two groups via a randomized sealed envelope method. A standard rehabilitation group, Group A, and a standard rehabilitation group plus electrical stimulation, Group B. Groups A and B received standard rehabilitation, and Group B received an additional 30 minutes of treatment for 5 days and 2 weeks, consisting of electrical stimulation of the wrist and the hand, then the finger extensors. Specifically, the extensor digitorum, extensor carpi radialis, and extensor carpi ulnaris were stimulated during the treatment within Group B. The parameters for Group B for the electrical stimulation intervention were a duty cycle of on for 10 seconds and off for 12 seconds, a pulse width of 250, a rate of 36 hertz, and a ramp up and down of 3 seconds. The intensity was increased to the patient's comfort. And Group A just received the standard treatment and did not receive an additional electrical stimulation. All statistical tests were appropriate for this study. The chi-squared observed the different frequencies for each categorical variable. The Wilcoxon rank sum evaluated the improvement of groups A and B, and the Mann-Whitman U-test assessed the difference between the clinical data and the demographic. Some strengths within this study were that although the treatment duration was short, the treatment itself was intense, which provided minimal but positive effect on improving upper extremity function and recovery. Another strength is that the statistically significant difference that there was between the Brunstrom and the motricity total scores within the delta gains. This study had a few limitations. A major component is the small sample size, causing subgroup analysis to not be examined. This small sample size also caused limitations to divide the groups into chronic and subacute patients. A key limitation that there was in the study was that it was unable to do a double-blind study, resulting in a single-blind study. And lastly, a limitation found was that the long-term effects of the participants were not observed. The statistically significant results from this study were that the Brunstrom and Motricity total scores from the delta gains were statistically significantly different between each group. A p-value of 0.008 and a p-value of 0.027. The clinically significant results from this study were that the Brunstrom hand results and the Ashworth elbow spasticity results had a statistically insignificant gain in the standard treatment plus electrical stimulation group, but is still being considered as an improvement within the study. There was also improvement that almost reached statistical significance within Group A compared to Group B, but for the Motricity index totals after treatment, there was not a difference. The authors concluded that based on the results, the functional electrical stimulation can provide a positive effect by enhancing upper extremity function and recovery in patients post-stroke. These results can be applied within practice by incorporating functional electrical stimulation into our treatment intervention plan to help decrease spasticity, improve strength, and awareness in patients post-stroke. And lastly, these results can be used in adjunct to a treatment plan to help decrease spasticity in adults post-stroke. In my future as an OT, I can use these results to provide evidence in deciding which modality to choose when needing to decrease upper extremity spasticity. Thank you for listening to my presentation.